This podcast is sponsored by GSK. Learn more at gskpro.com.
السلام عليكم ورحمة الله وبركاته. أحييكم مستمعين ومشاهدين بودكاست ReviveFM. أنا محدثتكم عزيزة بخاري, R2 Family Medicine Resident at Johns Hopkins Aramco Healthcare. Today, I would love to warmly welcome our very special guest here with us today, الدكتورة ملاك الشمري, Consultant Family Physician, Head of the Family and Community Medicine Department at Imam Abdurrahman bin Faisal University, and also the Chairperson of the Saudi Society of Family and Community Medicine. أهلا وسهلا دكتورة ملاك.
الله يسلمك ويرضى عليك. شكرا على الاستضافة.
أكيد نورتينا.
الله يسلمك.
ضيفتنا الأخرى دكتورة سارة العلي, R2 Family Medicine Resident at Johns Hopkins Aramco Healthcare.
Thank you, Dr. Aziza. It's an honor to be a guest, so thank you for having me.
It's an honor to have you with us. وضيفنا دكتور سليمان الصقير, R1 Family Medicine Resident at Johns Hopkins Aramco Healthcare.
يعطيك العافية دكتورة عزيزة, وشاكرة على الاستضافة, وإن شاء الله تكون حلقة مفيدة للمستمعين ولنا إن شاء الله.
الله يحييك بإذن الله. حياكم الله جميعا ونورتونا. بإذن الله حلقتنا اليوم حتكون جدا شيقة, ورح نغطي الحالات الشائعة في thyroid disorders اللي تجينا في العيادة. So we're going to have a lot of discussions about cases and hot topics in between. So let's start off with Dr. Malak. What is the prevalence of thyroid disorders worldwide?
So thyroid disorders حقيقة are amongst the most common endocrine disorders encountered في primary healthcare. The prevalence worldwide ranges from 1 to 2%. في الUS أكثر شوية, تقريبا 3%. It rises up to 10% if you count subclinical cases.
Right.
This is attributed to مثلا iodine deficiency or over-reporting في developed countries. But there's little يعني available data على prevalence of thyroid disorders في المنطقة هنا. فمثلا إيران, the reported prevalence was 0.2%.
طيب, what about Saudi Arabia? Are there any local studies we have here?
So recent literature revealed أن the prevalence of thyroid dysfunction, hypothyroidism to be exact, في السعودية is much higher. Some cases reported the incidence of thyroid disorders to be, or hypothyroidism, to be as high as 37% تقريبا.
Wow.
In some provinces في السعودية. طبعا hypothyroidism is 8 times more common في females than in males. It affects Caucasians أكثر من Afro-Caribbean races.
جميل. Since we mentioned a gender group, is there a higher prevalence in a certain age group?
طبعا زي ما قلنا إنه الفيميلز أكثر من الميلز. Hypothyroidism per se is much higher or much more common في elderly population. البريفالنس قد تكون up to 7% في people aged more than 85 years إلى تقريبا 89-90 years. طبعا this is TSH levels rise with age. عشان كذا حتى الآن في a lot of talk about age-specific TSH levels, especially في elderly population.
جميل.
Thyroid functions in general are very highly ordered في primary healthcare clinics.
صحيح, yes.
فمثلا في UK في 2019 thyroid functions were ordered أكثر من 12% في 1 year في العدد يعني around 1 year. والdiagnostic yield of thyroid function was more than 5%. So it's a higher percentage. That's why knowing your way as a family physician around thyroid functions and when to order, when to screen, these are very important and crucial for family physicians.
Definitely.
Dr. Malak, why is the diagnosis of hypothyroidism or hyperthyroidism often missed for months or even years?
I think the main reason إنه symptoms are not specific. فمثلا symptoms that are associated with hyperthyroidism زي nervousness, palpitations, shakiness could be attributed to anxiety مثلا. Other symptoms that are associated with hypothyroidism زي مثلا fatigability, confusion, which are more common في elderly. وأصلا hypothyroidism is more common في elderly.
Yes.
This is also a reason. Also كمان the symptoms are insidious in appearing. They develop over time. people get حقيقة accustomed to being confused and fatigued all the time. And patients don't really realize how sick they were until they actually become better.
Okay.
So this makes me wonder, who is at a higher risk of getting thyroid disorders?
So women, as we said, are more prone to thyroid disorders. Thyroid disease is much more common in people who have other autoimmune diseases. So patients with type 1 diabetes, patients with SLE, patients with rheumatoid arthritis. زي ما قلنا, elderly are more at risk of developing hypothyroid disorders in general. Other risk factors for hypothyroidism في history, as we said, the age. Hyperthyroidism disorders, autoimmune diseases, pernicious anemia, Addison's disease, histories of subacute thyroiditis مثلا, history of treated head and neck cancer, especially with radiation, مثلا other family members with thyroid disorders, patients who are taking specific medications. ما أدري دكتور سليمان تعرف some of these medications?
Yes, of course, دكتورة. طبعا في some medication can cause thyroid dysfunction يعني among individuals. One of them is lithium, used to treat people with bipolar disorder. It can lead to hypothyroidism in some individual. Other medication is amiodarone because it contains high iodine content. However, it can cause hypo or hyper in some individuals as well.
أحسنت, I agree. في other risk factors for hyperthyroidism also, دكتورة عزيزة. مثلا family members with thyroid diseases, non-goitrous patients, cigarette smoking مثلا, although the evidence here is still controversial and not very conclusive. Unexplained findings. في some conditions that when you find them and they're not explained could be attributed to hyperthyroidism as well. تعرفين دكتورة سارة some of these conditions?
Yeah, some of them may include atrial fibrillation, unexplained congestive heart failure, or even osteopenia.
أحسنتي. Excellent.
طيب دكتورة ملاك, we face many patients in the clinic asking for thyroid function test without expressing any symptoms of hypo or hyperthyroidism, or they don't have even risk factors as we mentioned before. Is there any recommendation or regular recommendation for regular screening for thyroid dysfunction among healthy individuals ولا لا؟
سؤال مرة مهم. حقيقة there is no consensus among organizations or among experts on when to screen, on how to screen specific individuals. Okay? في organizations تقول screen everyone above a certain age group. Other consensus don't really go with that recommendation. But targeted screening is always a good idea for patients who are أصلاً at risk or have other risk factors. But all organizations agree in the most sensitive parameter is the TSH level. Okay.
So now that we talked about screening, what are the general categories of thyroid disorders?
So we're going to talk about three main categories. Hypothyroidism, when the thyroid gland is unable to, it's underactive, so it's unable to produce thyroxine. The hyperthyroidism, where the thyroid gland is no longer under the direct control of the pituitary hypothalamic axis. And then thyroid nodules and thyroid goiters, where there's either uniform swelling of the thyroid, say goiters, with lumps here and there, which we call nodules.
Jamil. So inshallah, we're going to discuss these common thyroid disorders. Now, let's start with our first case with Dr. Sliman.
طيب. We had this case in the clinic for a lady. She was a 43 years old female, works as HR specialist. She was referred from another family physician due to a new onset of palpitation associated with diarrhea, nervousness, and hyperfeeling, according to her. Digging more in the history, she mentioned that she had one of her cousins had a thyroid surgery, but she doesn't know the reason.
But is there any physical examination findings?
Yes, physical examination vitally. She was tachycardic. Lid lag bilaterally were present, but no proptosis, no eye symptoms, no shakiness or muscle weakness.
Hello, Jamil. So what about her lab results?
Yes, lab result. TSH was ordered for her, and it was 0.1. Sorry.
So what do you think the diagnosis for this patient is?
So I believe that the patient seems to be clinically hyperthyroid, and it is actually confirmed by the low TSH levels.
So, طيب دكتورة سارة, يعني the question arises, what are the other differentials?
So there are some differentials, but the top one and the most probable one is Graves' disease. Other differentials include autoimmune thyroiditis and subacute thyroiditis with hyperthyroidism.
So do you think, Dr. Sara, you would need other testing, other additional tests to confirm your diagnosis? What do you think?
So there are other testing that we can use. We can use radioactive iodine uptake test.
أحسنتي.
Actually, radioactive iodine was done for her, which shows 43% 6 hours and 53% 24 hours.
Oh, so uptake is high.
Yes, it's high in both. So what's the final diagnosis after this scan?
I believe it is Graves' disease,
Yes.
as confirmed by the elevated radioactive uptake.
Jamil.
Exactly.
So since we discussed the most appropriate investigation, what are the treatment options for this patient?
So there are a couple of treatment options, and they should be discussed with the patient. They include radioactive iodine uptake. However, it is important to mention that one of the side effects include permanent hypothyroidism.
Okay.
And possibility of thyroid eye disorders. Other options include antithyroid drugs and even surgery.
So after choosing the most appropriate treatment, what happened to your patient afterwards?
So upon follow-up after 2 months, her symptoms disappeared. And TSH was 0.5 at that time.
Okay.
3 months post-treatment, she presented to the clinic again complaining of cold intolerance and puffiness of the
I
face.
see.
TSH was measured at that time and it was 80, which is very high. So this scenario shows a common scenario in the clinic, and it's common in clinical practice, which is post-radioactive iodine hypothyroidism.
Afterwards, how was she treated?
Patient started on thyroxine, for replacement dose on thyroxine, and she is on follow-up, and she is doing well.
Okay. So after being on full replacement dose, what happened to your patient upon follow-up?
She was fine at that time. Actually, upon follow-up, her TSH was normal and it was 1.7.
Okay.
Hello.
So I think we can discuss this case together. It has many points.
Yeah. So this case, actually, Dr. Sliman represents a very common presentation of hyperthyroidism. صح ولا لا?
Yes.
Symptoms of hypermetabolic state. صح? Hypermetabolism. She has palpitations.
Right.
She's cold intolerant. She's nervous all the time. Now, most of the hyperthyroid patients actually lose weight, but like our patient, she gained weight. صح?
صحيح.
Dr. Sliman, you
Yeah.
said that she gained weight شوية. Because of the hypermetabolic state.
Right.
Most significant finding on the physical examination of this patient was the goiter, صح? Which is very, the large thyroid,
Yes.
which is very common for patients with Graves' disease. Now, she didn't have any specific significant eye findings. She
That's
didn't
true.
have the ptosis. She didn't have the muscle, the eye muscle involvement. She had lead lag, but this lead lag is due to the androgenic state, and it could happen in any cause of hyperthyroidism rather than Graves' disease by itself. Okay. The low TSH levels, of course, confirmed the diagnosis of hyperthyroidism. So she was biochemically hyperthyroid. وطبعا radioactive iodine intake also confirmed the Graves' disease because it was high intake, both في أول 6 ساعات after 24 hours. So the high uptake confirms the diagnosis of Graves' disease.
صحيح.
لو كانت low uptake, then this is not Graves, this is most likely thyroiditis. Okay?
صحيح.
So the patient started on, she presented to the clinic complaining of hyperthyroid symptoms. After that, she developed hypothyroid symptoms. There are many learning points at this stage.
So yeah, Dr. Sliman, I do believe that there are many learning points. And one of the most important ones is that radioactive iodine uptake testing should be performed in a patient with hyperthyroidism so that we can differentiate Graves' disease from other causes of hyperthyroidism.
Very important.
Yes.
So the radioactive iodine uptake is usually elevated in patients with Graves' disease and very low in patients with thyroiditis with hyperthyroidism. And of course, this test should not be done in pregnant patients, and a good and reasonable alternative to it is the thyroid ultrasound.
Right.
Upon thyroid ultrasound, thyroiditis features actually can appear in the ultrasound, and findings could include thyroid nodules, and they are easily detected upon ultrasound. So back to the radioactive iodine therapy, it is actually one of the most common treatments for Graves' disease. It is very safe, it is very effective, and it usually results in a cure after one treatment only.
Wow.
And as a matter of fact, some patients with very large thyroids or severe disease may require additional treatments. And unfortunately, hypothyroidism is the expected result. However, it is very easily controlled with T4 in patients. There is an ongoing debate as to whether radioactive iodine therapy may have an adverse effect on Graves' ophthalmology or eye disease, but most physicians feel that the advantages definitely outweigh the disadvantages.
Agree.
Thank you, Dr. Sara, for highlighting these very important points. But this makes me raise a question. Can hyperthyroidism due to Graves' disease reoccur after treatment, Dr. Malak?
Very important question, Dr. Aziza. So it depends really on the modality of treatment.
Okay.
So patients who undergo complete resolution after radioactive iodine therapy usually don't get the Graves' disease anymore.
Okay.
They don't get ophthalmopathy, endocrinopathy again, or thyroid dysfunction again. But other modalities, like if the patient underwent subtotal thyroidectomy, مثلا, or lobectomy, or they opted for anti-thyroid drugs, carbimazole, PTU, they could have Graves' disease even years after achieving the euthyroid state. Okay, it's an autoimmune process after all, so you have to keep that in mind. Okay.
طيب دكتورة ملاك, in another scenario, if the cause of hyperthyroidism secondary for a hot nodule, what will be the approach?
طبعا. So you know hyperthyroidism مو شرط Graves' disease, ممكن تكون hot nodules ولا لا. So the first step that I want to emphasize in these patients who are biochemically and symptomatically hyperthyroid, you always should scan the patient. زي ما الدكتورة سارة قبل شوي قالت. The best modality of scanning is radioactive iodine.
جميل.
Let's say you don't have radioactive iodine, then thyroid ultrasounds are a very good alternative to radioactive iodines. Okay. So never manage your hyperthyroid patient. I'm talking about actual management. I'm not talking about symptomatic management. If you want to give beta blockers, NSAIDs, whatever, that's fine. But don't treat the hyperthyroid state unless you know what's the diagnosis. So scan your patients always. Okay?
That's a very good point. So now that we know that not all hyperthyroidism is Graves' disease, even though it is the most common cause, it's important to consider other causes before recommending treatment. What are the other causes, Dr. Malak?
Okay, so this is very important to consider other causes. So let's say it's a hot nodule. Hot nodules are good news, huh?
Yep.
Cold nodules are bad news. But hot nodules are almost always never cancerous. Okay, so this is good. It's a hyperfunctioning nodule. Okay. A thyroid scan is sufficient here. You don't need to send your patient for a FNA or a biopsy, because they are adenomas. They can be reported as suspicious, and this could be يعني في النهاية puts your patient under unnecessary surgery or unnecessary يعني procedures later on. Okay. طب let's say your T3, your T4 are normal, your TSH is a bit low, it's suppressed. Okay, the patient is not very symptomatic. You're wondering what this could be. This could be a subclinical presentation. So here you might opt for wait and see policy. You don't have to treat the patient right away, okay? Especially if the patient is asymptomatic. So there are some compelling indications to treat these subclinical patients. So let's say the patient is highly symptomatic, the patient's TSH is very, very low, or the patient has other conditions. The patient is in AFib, or the patient is osteopenic or osteoporotic.
Right.
So it's a very good practice to scan the bones of the patients, DEXA scanning of the patients with low TSH levels, because if they are osteopenic, then you might opt for treating those kinds of patients. Okay?
Jamil. Very well put and thoroughly explained. Thank you, Dr. Malak.
You're very welcome. So يعني أنت قلتي عن ال differentials. So let's dive into other differentials, Dr. Sara. What do you think are the other differentials of a low TSH and the hyperthyroid status?
Dr. Malak, I think one of the most important differentials to keep in mind is subacute thyroiditis. And it is actually a clinical diagnosis based mostly on history and physical examination of the thyroid. So usually the gland is painful and tender to touch. It has a very long course, and patients can present with low-grade fever. And they usually have a high ESR, but normal blood counts. As for thyroid function testing, it can be normal or slightly towards the hyperthyroid state. The hyperthyroidism in this case is not the result of an overactive thyroid. It is important to mention that it is usually caused by leakage of performed hormone from an inflamed and damaged thyroid.
Excellent, yes.
Other testing, such as autoantibodies, are usually negative. And a good thyroid examination might reveal an enlarged and diffusely tender thyroid. But it is very important to mention and remember that thyroiditis, whether painful or painless, they have a very low and uniform uptake on radioactive scans.
Excellent, yes.
Very nice.
As for treatment, steroid therapy usually can dramatically control symptoms in subacute thyroiditis, but it will not affect the course of the disease. It's important to mention that it should be used in pain and if the symptoms are very severe and debilitating. And a high dose is usually needed, and it should be tapered slowly to avoid flare-ups.
Right.
However, in mild cases, usually non-steroidals are sufficient enough to control the symptoms.
جميل. يعني ما شاء الله, we have discussed a lot of important points, and I personally learned significant things from this very enriching discussion. So thank you, Dr. Sliman, for sharing your case with us, and thank you, Dr. Malak and Dr. Sara, for your inputs. مشاهدينا مستمعينا الكرام, فاصل ونرجع لكم.
Shingles is a painful disease that can have serious and long-lasting complications. And the burden of shingles increases as the person ages, with a steep increases in adults above 50 years due to age-related decline in immunity. Shingles vaccine can provide up to 90% protection against shingles. Saudi Arabia's Ministry of Health recommends 2 doses of Shingrix, 2 to 6 months apart, for all adults ages 50 years or older in their national immunization schedule.
رجعنا لكم مستمعينا مشاهدينا with a new case that I believe Dr. Sara, you would like to share with us?
Yes, thank you, Dr. Aziza. So as for my case, I have a 42-year-old woman complaining of a 10-kilogram weight gain of a period of 4 months. She has also complained of cold intolerance, irregular menses, constipation, and dry skin. She had been working full-time in an office and noted that she gets tired a lot more easily. And family history was negative for thyroid disease, and she was not on any medications.
Okay. Were there any significant findings in her physical examination?
Okay, so as for physical examination, it revealed a pulse rate of 72 beats per minute and a blood pressure of 120/82 millimeters mercury. There were no thyroid eye signs, and the thyroid was diffusely enlarged to about twice the normal size, and it was non-tender. Examination was otherwise unremarkable.
What about her lab results?
So as for the lab results, they showed a total T4 of less than 2.5 and a TSH of 18, and autoantibodies were negative.
Great.
Okay. So what's your diagnosis, Dr. Sliman? What do you think?
So I think this is a classic presentation of primary hypothyroidism. Patient presented with clinical symptoms of hypothyroidism with biochemical findings like high TSH, low T4.
Ahsan. So would you need additional testing?
In this situation, we don't need any order for this patient. Actually, the diagnosis can be made with those findings.
I agree.
So, Dr. Sliman, how would you treat this patient?
So, the mainstay of treatment in case of primary hypothyroidism is thyroxine. Thyroxine once daily, we start slow and low, and we increase the dose upon follow-up if needed. طبعا the full replacement dose of thyroxine is 1.6 microgram per kg. However, we need to keep in our mind that we don't need a full replacement dose. Many patients can achieve euthyroid status by lower doses.
Exactly. Excellent, Dr. Sliman. So back to our case, the patient was actually started on 50 micrograms of T4 daily, and she presented 1 month later. She noted a decrease in fatigue and cold intolerance. However, she now complains of hair loss and muscle aches. Her total T4 was repeated and it was low to normal at 6.5. TSH was 11. And upon physical examination, the thyroid remained enlarged. So the decision to increase her dose to 75 micrograms daily was taken.
So after increasing her dose to 75 micrograms, how were her symptoms upon follow-up?
Okay, excellent question. So we actually followed her up a month later, and most of her hypothyroidism complaints had improved except for the hair loss.
I see.
And her TSH was also repeated, and it was normal at 1.8. As for her free T4, it was 1.2. Okay.
Other than the hair loss, how was her thyroid during examination?
Upon physical examination, the thyroid had decreased to about 1.5 times the normal. So she continued to take the 75 micrograms daily, and she was followed up 3 months later. So after 3 months, she was feeling generally well, and her menses had returned. Her thyroid was only mildly enlarged. TSH was also repeated, and it was low to normal at 1.2. She was continued on 75 micrograms of thyroxine daily and advised to return for a yearly follow-up.
Jameel. So this is a very common scenario we face in the clinic. But Dr. Malak, can you elaborate more on it, especially in Hashimoto's thyroiditis? What are the clinical pearls in this case?
Okay. So Hashimoto's is the most likely etiology of hypothyroidism and goiters, as you know. The autoantibodies are often positive. They can be negative, like in our patient. Biopsies always show a picture of thyroiditis, which is the lymphocytic infiltration. young patients here without any heart disease, without any other comorbidities can be started on a full replacement dose, as Dr. Sliman said, which is 1.6 micrograms per kg.
Yes.
We opt to start lower and slower because a lot of patients can, as Dr. Sliman said, achieve the euthyroid status and become much more symptomatically better on lower doses. But you can start with the full replacement dose if the patient general condition allows it.
I see. Like, when do we check for the response of the treatment, and what is the first parameter to change from the thyroid function test?
So as we said, we can elect to start some patients on less than the full replacement dose or the full replacement dose. This is left on the physician's discretion and the general condition of the patient. But when you give thyroxine, the general rule is to give it time to work. Okay, so don't be hasty into ordering the thyroid functions على طول once you start thyroxine. Give it at least 6 weeks, 6 to 8 weeks generally, okay? Keep in mind that the T3 and T4 levels, mostly T4 levels, will change faster than the TSH levels. So this is a parameter that you need to keep in mind. Hashimoto's is familial. Maybe it's a good idea to bring the patient's family members, first-degree relatives to screen them also. And also, keep in mind that sometimes the patient can have other deranged parameters. Patients could have مثلا increased liver functions, hypercholesteremia. So if you have this as the initial presentation and you don't think thyroid, think thyroid. So if you don't think this is thyroid, you might lose the patient, and put the patient on unnecessary testing and just prolong the course of treatment in general.
Yes.
So just keep thyroid in the back of your mind.
Jamil. So think thyroid. I believe this is our new slogan of today's episode, and to keep it in mind when we find deranged lab findings in the clinic. So thank you, Dr. Malak, for mentioning that. So let's now jump into a different angle. There are recent studies about treating hypothyroid patients with T3 rather than thyroxine. Can you dive into this topic, Dr. Malak?
So, Dr. Aziza, the generally accepted treatment and management of hypothyroidism is thyroxine, as you know. Now, T3 is the active form of thyroxine, it's the active form of the hormone and on the level of the nuclear receptors, okay? So, most of the studies that touched on that matter كان عندها نقطتين مهمة. أول نقطة إن it's used for patients who achieve the euthyroid status biochemically, but clinically they're not feeling very well. Okay, and the mainstream of management is always combination therapy. So you don't need it, or you don't use T3 alone. So the general idea إنه to lower the thyroxine T4 ونحط شوية small dose of T3 in combination with T4. So maybe 5 to 12.5 milligrams تقريبا of T3 with the lowering the dose of T4.
Jamil.
So as we said, the consensus is to use it in patients who feel physically unwell, although they have achieved the euthyroid status. It's not a good idea to start T3 in patients with underlying cardiac conditions. So just keep that in mind, okay? بس يعني in general, the end results are not always promising. ما في big difference between a T4 alone with T3 combination therapy with T4.
I see. So in summary, it's best to stay in the mainstream treatment with thyroxine.
وحتى هو مش readily available everywhere. T3, okay?
Jamil.
If you allow me to share another case we had in the clinic.
Of course, go ahead.
So we had a lady, she was 36 years old, female. She presented to the clinic complaining of a goiter. Upon taking history, she admitted that she had 2 previous episodes, similar episodes. One episode when she was 20 years old.
I see.
The doctor decided to start her on thyroid medication. She started thyroid medication for 1 year. She doesn't know the medication, by the way. And the goiter disappeared, and she stopped the medication.
I see.
Approximately after 6 years, she developed the same symptoms with the same medication, and she did the same. Once the symptoms disappeared, she stopped the medication. Now she came to the clinic complaining of the same issue before.
So what about her physical examination? Any findings?
So physical examination, vitally she was stable. She had a thyroid enlargement, diffuse thyroid enlargement. It was non-tender. However, the right lobe larger than the left lobe.
I see.
Other than this, it was negative.
Great. But what about her lab tests?
Yes. After that, we ordered TSH and for her and T4. TSH was 11 and T4 was 0.9.
Jamil.
So what? Autoantibodies was 697.
Okay.
So at this point, with the autoantibodies findings, what's the diagnosis?
I believe with these results, it's mostly Hashimoto's thyroiditis. So I would initially start the patient on 50 micrograms of levothyroxine daily as a treatment for both the hypothyroidism and the goiter.
Yes, indeed. This is what happened with the patient. Patient started on thyroxine 50 microgram. However, upon follow-up, her TSH was 0.2, which was overtreated. So we reduced the dose to 25, and she's doing well now.
حلو, Jamil. So directing this question to you, Dr. Malak, what are the indications of treating a patient with thyroxine?
So in this patient, exactly, was her previous response to thyroxine therapy.
Okay.
So this is the first indication to treat. بشكل عام, the presence of a goiter is an indication to treat with thyroxine because it shrinks the goiter. Subclinical cases, subclinical hypothyroidism, keep in mind it might progress to overt hypothyroidism.
Right.
Especially with the positive autoantibodies, like in this patient, she has highly positive autoantibodies. طبعا the rate of conversion of subclinical hypothyroidism to symptomatic overt hypothyroidism is at تقريبا 5% per year. So it's a big rate يعني. So we should keep this in mind. Don't forget to at least annually recheck your patient and book them in the clinic. Definitely. Because even if they achieve euthyroid status, they might need dose adjustments. Like this patient, she lost follow-up for 6 years, then she came back. So this really highlights the importance of annual follow-up at least.
Definitely. Yes. Thank you for highlighting that. Well, Dr. Malak, as you know, Hashimoto thyroiditis, it has various presentation. It confuses our clinical judgment sometimes. So what does it usually present with?
So Hashimoto's can present with goiters alone. They can present with goiters with hypothyroidism.
Okay.
They can occasionally present with hyperthyroidism in the beginning, then progress to overt hypothyroidism. Subclinical hypothyroidism is a very big presentation of Hashimoto's with regression to overt hypothyroidism later on. Goiters are often diffuse in Hashimoto's, but also some patients might also present with multinodular goiters. Okay, so they, as you said, various presentations. Now the hallmark is the lymphocytic infiltration, as we said. So if you biopsy the patients, they mostly have a picture of thyroiditis with lymphocytic infiltration. There is no need to biopsy the patient, but I'm saying if you biopsy these patients, then they would have a lymphocytic infiltration.
Jamil, so we should always keep Hashimoto's thyroiditis in our mind, with, especially you don't know when they present to our clinic. So let's dive into subclinical cases in hypo and hyperthyroidism. We face plenty of patients diagnosed with this. Many of us residents, we are also confused about what it is, how to diagnose it, how to treat it. So Dr. Malak, can you help us with this, please?
So subclinical thyroid disease is a very hot topic now. Okay, it's emerging. Recent data, recent consensus, guidelines كثير تغيرت في subclinical hypothyroidism و hyperthyroidism in general. بشكل عام, the concept of subclinical disease, subclinical thyroid disease was achieved or يعني out there لما TSH specific sensitive TSH levels were discovered in the mid 1980s تقريبا. منها صرنا نقدر we diagnose subclinical cases. Okay, so Dr. Sara, what do you think, or Dr. Sliman, what do you think is the subclinical hypothyroidism?
Of course. طبعا subclinical hypothyroidism defined as an TSH higher than the reference range with a normal T4 in a symptomatic individual.
أحسنت. So high TSH?
Definitely. But what are the other causes of an elevated TSH?
So other causes of elevated TSH you should always keep in mind, مثلا recent change في thyroid hormone replacement doses, acute illnesses, a recovery phase of thyroiditis. يعني try to rule these out.
Yes, Jamil. But what if we had a case that was opposite with a low TSH?
So this is the opposite, صح? Yes. Subclinical hyperthyroidism. Yes. So it's defined as a low TSH. Most of the time T3 and T4 are normal and the patient could be mildly symptomatic ولا حتى asymptomatic at all. صح ولا لا? Other causes of low TSH that you should always keep in mind are sickle thyroid syndrome, which is the non-thyroidal illness.
Yes.
Could be overtreatment of thyroxine, could be persistent low TSH after the treatment of hyperthyroidism with radioactive iodine therapy. صح ولا لا؟
Yes.
In the postpartum period, acute postpartum period also.
صحيح. طب ما شاء الله دكتورة, since you brought up postpartum, this reminds me of a special population, which are pregnant women.
Yes.
So when, how, whom to screen, how to diagnose, when to treat, I have endless questions about this topic. And I hope you can clarify it for us.
I'll be more than happy to do so. I believe Dr. Sara has prepared something. So, بعقب على Dr. Sara.
Yes, exactly. Thank you, Dr. Malak. So actually, thyroid disease diagnosis and treatment during pregnancy is a very complex process because we are concerned about two entities, the mother and the fetus.
صحيح.
Can you further explain why it's difficult and to diagnose and treat?
Okay, so as for the diagnosis, it is a lot more difficult and complex because thyroid testing might be a little harder to interpret during pregnancy. And one of the tests, including radiation testing, such as thyroid uptake and scanning, it is contraindicated in pregnancy, and it cannot be safely performed in pregnant patients. As for treatment, it is a lot more difficult because of the concern of the effect of the thyroid disease and medication on the fetus himself or the fetus herself. Radioactive iodine treatment is contraindicated during pregnancy also.
بس إذا تسمحوا لي أضيف نقطة بعد إنه thyroid dysfunction postpartum is common.
Yes.
And usually it's missed because patients, they present with non-specific symptoms like depression, nervousness, anxiety, palpitation. And often it's mixed up by physicians that because of a new lifestyle changes and taking care of a new infant and mostly lifestyle. So statistically speaking, thyroid dysfunction postpartum, it reaches up to 20% among women.
Wow.
And usually it's transit, but the awareness and treatment should be considered for lifestyle changes.
Yes, definitely.
نقطة جدا مهمة. Excellent, Dr. Sliman. Because a lot of physicians are so hasty to أنهم يعيزون هذه new symptoms that and the complaints that the mother is complaining of in the acute postpartum period to just lifestyle changes, to mood disorders after taking care of a new infant. صح ولا لا?
Yes,
So, and women are not usually satisfied with that kind of diagnosis. صح? And they just يرفضون or reject these kind of diagnoses.
Yes.
So once you tell them that this is a thyroid disorder, even if it's transient, even if it doesn't need treatment, but actually knowing that there is a diagnosis, an actual diagnosis, hormonal imbalance, this makes them خلينا نقول much more satisfied.
Definitely.
Yeah, the good news is it's transient most of the time. It's very easily treatable, but satisfaction حقهم يصير أعلى.
أكيد. Yes.
So, Dr. Sara, can you give us a brief about the normal thyroid physiology in pregnancy?
Okay, of course. So actually there is a 20 to 40% increase in thyroid requirements during pregnancy, as early as the 4th week of gestation. And it is actually because of the estrogen-mediated increase in thyroid-binding globulin and the increased volume of distribution of thyroid hormone and the placental metabolism and transport of maternal thyroxine.
طيب, what about asymptomatic pregnant women with subclinical hypothyroidism? Do we screen them?
مرة مهم السؤال هذا. So choosing wisely campaign, which I'm very passionate about, لأنها حقيقة يقنن الأشياء اللي gray zone, you don't know to do it, to order it ولا لا. So the choosing wisely campaign has opted not to screen asymptomatic pregnant women for subclinical hypothyroidism per se. Now keep in mind in subclinical hypothyroidism during pregnancy mostly does not evolve into clinical hypothyroidism في pregnancy itself. So if it's going to revert to hypothyroidism, then mostly it's بعد pregnancy. Okay? So there is no need actually to screen your patients of subclinical hypothyroidism during pregnancy. Asymptomatic women. We're talking about asymptomatic women. Recent studies, very big, large randomized clinical trials كان فيها أكثر من 100,000 female
ما شاء الله.
followed their patients up for subclinical hypothyroidism 5 سنوات بعد الدليفري للIQ والschool performance of their kids. They found there is actually no difference between the patients who took thyroxine and who didn't take thyroxine for asymptomatic subclinical hypothyroidism first discovered during pregnancy. Okay. Now we're not talking about overt hypothyroidism and we're not talking about patients who have been diagnosed before getting pregnant. We're talking about initiating screening and treatment in pregnancy per se for subclinical cases. That's why maybe it's not a good idea to screen all females for subclinical hypothyroidism. Now keep in mind that specific patients with specific risk factors and targeted screening is still appropriate.
Yes. Thank you, Dr. Malak, for sharing this important study with us. Like, what are the indications of thyroid testing in pregnancy then?
So there are certain indications for thyroid testing in pregnancy. It's if the patient is currently undergoing thyroid therapy or if the patient has a goiter. As for past history, if the patient has any past history of autoimmune disorders, past history of hyperthyroidism, any previous delivery of an infant with thyroid disease, high-dose neck radiation, autoimmune disorders such as type 1 diabetes and others, or if the patient has family history of autoimmune thyroid disease.
طيب, since we discussed hypothyroidism in pregnant women, what about patients with hypothyroidism that are still planning for pregnancy? How can we properly counsel them?
Very good question. So women with hypothyroidism should be counseled on preemptively increasing their thyroxine even before getting pregnant. So we're talking about patients who have been diagnosed with hypothyroidism on their regular doses of thyroxine for a while now. They're achieving their euthyroid status. Now they're planning to get pregnant, so they preemptively should increase their thyroid doses, okay? Or at least as early as once they miss a period or they have a positive home pregnancy test, okay? So how would they increase their thyroxine? By adopting the 9-dose regimen, okay? So what's the 9-dose regimen? It's 2 days per week. You take double the dose of thyroxine. This is the 9-dose regimen, okay?
Nice.
طبعا requirements of thyroxine زي ما قالت الدكتورة سارة would increase as early as the 4th week of gestation. That's why it's very important to reach TSH trimester specific levels في as early as possible. Okay. طيب, let's say the patient started her thyroxine or she got pregnant, then you should retest the TSH level of the patient every 4 weeks. خلينا نقول especially في الفirst trimester. Or reaching the TSH specific trimester range at every trimester. Once you hit 20 weeks of gestation, 16 to 20, بس خلينا نقول 20 weeks of gestation, then maybe TSH could be measured at least once until 24 weeks of gestation. بعدين من 32 to 34 weeks at least once also. Okay? Always keeping in mind that you achieve مش بس euthyroid state, لا, حتى TSH level لازم تكون في trimester specific TSH level في pregnancy.
Perfect. Thank you for beautifully summarizing that, Dr. Malak.
طيب, دكتورة ملاك, and I have one question.
Sure.
We have been through the literature, and it says some studies says that there is a possible link between GLP-1 agonist and thyroid cancer. So, what's your opinion?
صراحة ما شاء الله تبارك الله كل الأسئلة اليوم يعني very common و very prudent صراحة, especially هذا السؤال دكتور سليمان لأنه يعني حديث المجالس صح؟
Yes, of course.
أصلاً GLP-1's receptor agonist الآن هم يعني الهايب.
Yes.
So في كل جلسة في كل هذا يعرفون إنك physician, so they ask you about it. صح؟ فالpharmacovigilance risk assessment committee اللي هي تابعة للEuropean Medical Agency, they gathered all the data, post-marketing, pre-marketing, clinical trials, human trials. They have found that there is the available evidence now does not support any causal association between the GLP-1 receptor agonists اللي هم السemaglutide والliraglutide والdulaglutide مع thyroid cancer. Okay. So في نقطتين أبغى أرجع عليها. أول شيء thyroid cancers in general صحيح إنها the 9th cancers most common cancers worldwide, بس they are not in the top 20 بالنسبة للمورتاليتي ريتس. هذا أول حاجة. Okay. So a second thing, من يوم ما طلعت الهايب عن GLP-1s مع thyroid cancers وكذا, doctors were actually looking for thyroid cancers or thyroid diseases. They're actively looking for it once they start GLP-1s. Right. Okay. So that's another thing. Also GLPs reduce weight. So الجويترز أو النوديولز تبان أكثر once you lose weight.
That's true.
فالنقطة هذه is called detection bias. Okay. So when you're actively looking for something, you're actively screening for it. You're overly diagnosing it. Okay. So هذه could be one explanation حقيقة for the hype of إن ال GLP-1s are associated with thyroid cancers. You could have thyroid cancer even without the GLP-1s. Okay. But it's more evident now because you're actively looking for it.
Right.
And that's the concept of detection bias. And this is something that we need to keep in mind.
Yes,
okay.
Definitely.
فيعني دكتورة الخلاصة إنه no link between the thyroid cancer وال GLP.
There is no proven link.
Still.
No. There is no, in humans, there is no proven link.
Perfect. Thank you for mentioning detection bias. And this is very important to consider when we're treating our patients in the clinic. And also, Doctora, thank you for closing Hadith al-Majalis and clearing that out for everybody. This hot topic was thoroughly explained, to be honest. But unfortunately, we have come to an end to our episode today. But before we conclude, Dr. Malak, we would like you to give us a take-home message. What are the pearls of our very rich discussion today?
So I think the most important messages صراحة to take من الحلقة اليوم هي أول شيء, as we said, think thyroid.
Yes.
Okay. So just keep in the back of your mind. Sometimes أشياء تكون يعني معقدة مرة والpresentation حقتها قد تكون easy once you just order a thyroid function for the patient.
Right.
Okay. هذا أول حاجة. Second thing is about hyperthyroid status. Scan your patients always when they are hyperthyroid because you need to know what is the reason for their hyperthyroid state before treating the patient. هذا second thing. شيء ثالث about screening for subclinical hypothyroidism first time for pregnant ladies. زي ما قلنا choosing wisely campaign.
Yes.
Maybe we opt not to screen patients with no risk factors في pregnancy first time with a TSH, especially for subclinical hypothyroidism. رابع نقطة حقيقة هي know your limitation and the importance of shared management of thyroid patients with an endocrinologist once needed. مثلا hypothyroid patient that needs a mega dose of thyroxine, which is more than 200 micrograms تقريبا. This needs to be shared with an endocrinologist. Hyperthyroid patients that need scanning, radioiodine scanning, need to be shared with an endocrinologist. Other thyroid emergencies, thyroid storms and myxedemas need to be shared also with an endocrinologist. So these are my take-home messages.
Thank you for delivering this take-home message. It was beautifully explained. We deeply appreciate your presence with us, Dr. Malak, today, for sharing your knowledge with us. وجدا ممتنين لحضورك معنا اليوم والله.
الله يسعدكم جميعاً وسعيدة فيكم وبالدكاترة وإن شاء الله تكون الحلقة مفيدة للجميع ودعواتكم.
إن شاء الله بإذن الله. وأشكر ضيوفنا دكتورة سارة ودكتور سليمان، يعطيكم العافية. الله يجعل هذا العمل في ميزان حسناتنا يا رب.
الله يعافيك إن شاء الله.
ونشكر كذلك فريق ReviveFM من اللجنة التنظيمية واللجنة التعليمية العلمية والإعلامية، ما قصروا معنا أبد. فوصلنا لنهاية حلقتنا اليوم مشاهدينا ومستمعينا الكرام. أي شيء تحتاجونه تلاقونه في صندوق الوصف. لا تنسون تشاركون هذا الفيديو حتى الجميع يستفيد. فشكرا لكم ونراكم في الحلقة القادمة.
This podcast is sponsored by GSK. Learn more at gskpro.com.